Perfect.
All right, great. Good afternoon, everyone. Good evening. Welcome to this 18th webinar by Caregiver Saathi as part of our Compassionate Caring series. Today, we focus on a theme that is close to a lot of people, which is essentially long-distance caregiving and palliative care for the elderly. And in this session, we'll be basically understanding more about the psychological well-being part. So, while I fix this thing, yep. My colleagues are sending me lots of instructions, so sorry about that. As a quick introduction to Caregiver Saathi, our goal is to create an ecosystem of well-being and healing for the primary caregiver. Family caregivers are of those navigating terminal illnesses, chronic or other life-limiting conditions, have their unique challenges, and we support them through their caregiving journeys as well as beyond that. So what we wish to do is create an environment of well-being by empowering caregivers and help the caregiver and the care receiver or the patient lead full lives. So while we're trying to go live with this, in the meantime, so how does Caregiver Saathi go about doing this? We provide technology-enabled systems which provide a human connection. This is through awareness programs, online as well as offline. We have a helpline. We have healing circles where we meet fortnightly. We actively engage on social media to provide access to relevant information through our website and other digital assets, as well as a tech-enabled platform. Would request everyone to be on mute till the participant session. Which are the resources that we've built so far? We talked about our digital platform, app and website. We have online and offline education tools. We're building a community on Facebook, which you can be a part of. We have the Gentle Warriors Caregiver Stories. We have training sessions and more focused inputs from experts, like we have Dr. Leena today in the Compassionate Caring series. We also provide caregiver coaching, family counseling, as well as volunteer-based respite care. How can you get involved? You can join our support groups. You can help share your caregiving stories or help us reach out to caregivers who might be interested in sharing their stories to support people who are active caregivers currently. You could spread the word in person on social media. You can volunteer. You can help donate or raise funds. And you can help refer us to other organizations and hospitals and healthcare systems that you feel could be useful to this cause. The younger generation, of course, can help in turn with us. So what does Caregiver Saathi do? In a sense, we have an operating framework for helping understand well-being, and we have various tools to address the various elements of well-being and resilience for our caregivers. These include physiological, spiritual, psychological aspects at the core, and inward-looking aspects. Then we have the social well-being, financial and legal well-being, as well as work-life purpose and creative expression. The research that we've done shows that stress is caused by an imbalance in well-being, and unaddressed chronic stress leads to mental health issues. And to build resilience, we need to build practices which encompass mind, body, and soul. Introduction to our speaker for the topic today on long distance caring and palliative care for the elderly. Dr.Leena V Gangolli. Dr. Leena has completed MBBS from Mumbai University with a master's degree in public health at the Tata Institute of Social Sciences, followed by a master's in public health from the Harvard School of Public Health in Boston. After returning to India, she pursued a master's degree in human rights law, in which her dissertation was about establishing palliative care as a human right in India. She's an author and editor of the book Review of Healthcare in India and other publications related to health and human rights in India. She served as a member of the ethics committee of the Tata Memorial Hospital and serves as the chair of the ethics committee at the King Edward Memorial Hospital, KEM Hospital in Mumbai, and is also associated with Silver Innings, an NGO that focuses on families which have people affected by dementia and Alzheimer's. In addition to her own medical practices, she conducts training in geriatric palliative care for palliative care professionals, volunteers, and family caregivers in association with IAPC, the Indo-American Cancer Association, Cipla Palliative Care, and other community-based groups. She's also a member of the National Task Force Palliative Care appointed by the Ministry of Health and Family Welfare, Government of India, and the Technical Advisory Committee for Geriatric Health Policy by the state of Maharashtra. And based on my personal experience, she comes across as a completely unassuming and less foreboding person than what that introduction sounds like. With that, welcome, Dr. Leena.
Thank you. Thank you, Aneesh. So at the outset, I'd like to thank everyone at Caregiver Saathi. So Bhavna, Aneesh, Navya, Anjali, everyone we've been working together to get ready for this. And thank you all, everyone who's participating today. Thank you all for taking the time to be here. I know it's Christmas, so you could have been doing so many other things. So thank you for being here. So I guess we'll start. So Aneesh, would you like to, are we going to start with the...
What we'll do is, we're going to have three parts to this session. The first will be a kind of a quick presentation and a conversation between the two of us on the topic at hand. After this, we'll address some of the questions that have been raised by the participants. Mm-hmm. And we'll also get into a live Q&A depending on what questions people have. So maybe we could just kickstart with, your views on the topic that we've chosen on long distance caring and elderly care, palliative care for the elderly, and just sort of go from there.
Okay. So before we start, I just want to understand from the group, if we do have a polling question, how many of you are already caring for someone? So how many of you are already in a family caregiver role? Is there any way we could?
Yeah, Nabia is just going to launch the poll on that. As soon as the results come in, we'll be sharing that.
Okay.
Zavir, thank you.
Okay, so we have a lot of active caregivers right now, and a lot of them are females. Okay. So I do want to add that although with our poll, a lot of our caregivers are females, that might just be because that's the attendance that we have today. But I do want to say that I've worked with a lot of families where there are male caregivers as well, and they have fulfilled the role just as well. So although we often say that the burden of caregiving is on women, I do want to acknowledge that there are a lot of caring sons, husbands, brothers who also fulfill the role of caregivers. All right, so let's just start with the basics then. I'm going to first talk about palliative care.
Yep.
So let's just first thing is that palliative care deals with life-limiting conditions. So these are conditions which may not have a cure, but certainly require care. And they limit the quality of life in some way, all right? Either the functionality or we'll come to how they affect the quality of life. So it's dealing with life-limiting conditions. Secondly, palliative care aims to address distressing symptoms that are associated with these conditions. So although the management is not curative, it does address symptoms, all right? So it may not cure the underlying condition, but it seeks to address the distressing symptoms that are associated with that condition. And the third very important aspect with palliative care is, compared to other disciplines of medicine, the unit of care is not only the patient. The unit of care is the patient plus the family or the caregivers around the patient. That's very important for us, and especially in the care of the elderly. It's very important for us to find ways to care for both the elderly and the caregivers around the elderly. So that's what the basics of palliative care are these. And one more thing that's very important that I want to clarify is a lot of people, there's a misconception that palliative care is necessarily a sort of end of life care, or it's care which is given, in the last weeks or months of life, which is incorrect. Palliative care starts at the time of diagnosis of any life-limiting condition, and it aims to be supportive to both the person facing that condition and the family and the caregivers around the person. Okay, so those are the basics about palliative care. Now, today's topic is on long-distance caring. So before I come to long distance, I want to say one more thing about family caregivers. What happens with family caregivers is the caregiving provided by family members is often under-recognized and under-acknowledged, both in society and in general, like in the way we're trained. So I think it's really important that Caregiver Saathi is having these webinars and is creating resources for family caregivers, because they play an extremely important role in palliative care, and especially in the care of the elderly. And now with long distance caregiving. So with the pandemic, of course, there were a lot of travel restrictions and people were unable to come and be with their loved ones. So in the context of the pandemic, people were forced to be in long distance caregiver roles. But even outside of the pandemic, these days, because of the way the world is changing, there are many situations where family members are not necessarily living together anymore, and therefore family members do play the role of caregiver from a distance. All right, so we're going to talk about how we can best fulfill that role. So one of the things that we were discussing when we were brainstorming on this session was the issue of preparedness, and how it's important to be prepared as a family caregiver. And I think when we were talking about this, someone did say something about being prepared for a crisis, but I actually believe that preparedness starts well before that, because if we start getting prepared in good times, then it definitely makes a crisis situation easier to deal with if and when that situation is precipitated. So I'm going to sort of discuss with all of you, and if many of you are already active caregivers, I'd love to hear from you how you are coping with this. But we'll just start with maybe a kind of roadmap for how we could create a plan for care. This is just an idea that I'm sharing with you. I obviously invite inputs from all of you because I know that you are experiencing this and you are living this too. So the first thing is a plan. So now to have a plan, we need to know where we are right now. If we know where we are right now, it gives us an idea of what we need to plan for going forward. And it gives us a little bit of preparedness in case there is some sort of crisis or some situation that would involve an intervention. So a checklist that I think would help is when you're planning. So now let's just take a concrete example. Suppose you have elderly parents living in the city and you as children are living in another city or another country. So you're not going to be physically present with your parents. In such cases, there needs to be a plan for how you're going to help from a distance. So what I think is you start with, obviously it's got to be an open discussion. It's a collaborative process, okay? So this will be a conversation with your parents and you'll explore options together as to how to best have this plan. And you start with an assessment of where you stand right now. So what I find helps in making an assessment is looking at all the intrinsic factors first, of the factors that are directly related to the loved one. So that's their physical issues, any intellectual or mental issues, emotional issues, and their capabilities, things that they're able to do, things that they require assistance doing, okay? I'm going to give you examples on this. So those are the intrinsic factors. So physical, mental, emotional, and function, okay? And then there are external factors, which you will all review together. Those would be the environment. And when I say environment, I mean, for example, the place where they live. So I'll come to that. So is that place a safe environment for them to be in? Is it suitable given their physical condition, etc.? And the last thing is social networks, community, external resources that you would have. So let's start with physical. You need to take a realistic assessment of where your loved one is physically. How is their mobility? Okay. Do they have issues like osteoarthritis, balance issues? Do they have issues which would impair mobility? And therefore either restrict them from being able to go out and access things or would put them at a risk for falls. Then another thing you need to review for the physical assessment is vision, hearing. Are there any impairments that we need to address? Are there any early cataracts that can be addressed before vision is impaired? Hearing loss, that's important. Issues of dentition. Are there loose teeth? Is there a need for dentures? If there are dentures, are they well-fitting, ill-fitting? Could there be ulceration in the mouth that we may not be aware of? So these are physical aspects. Now I'll come to how these physical aspects will play out with functionality and will play out with environment in a minute. The next thing that we will review is the intellectual capacity of this person. So will they be able to handle things like bank transactions, handling money, shopping? Are these things that they can do? Can they drive for themselves, for example? So these abilities which would involve cognition, where do they stand as far as that assessment goes? And the next thing is emotional needs. Is the parent, now if the person is fortunate to have both their parents, but if one of the parents has passed away and the other surviving parent is dealing with grief and bereavement, is there a social support system for this person? So what are their emotional needs going to be? And function or capability. Function or capability would be, what are the things that this person can do for themselves? So things like cooking for themselves, shopping for themselves, getting daily tasks done. Can they, again, as I said, can they operate an account? Can they handle things like paying bills and things? Okay, those are capabilities. The next assessment is the environment around them. So the house. How safe is the house? Does the house have any furniture or fixtures which could increase the risk of falls? So for example, could the bathroom floor be potentially slippery? Do you need handrails fixed in the bathrooms? In the living room, are there carpets or rugs which could be potential things to trip on? Are the seats comfortable and safe that a person could sit without a fall? In the bedroom, are there, for example, bedspreads that have tassels on them? I've had patients whose toe has been caught in the tassel of a sheet, and they've actually fallen because of tassels on bed sheets. So your assessment of the environment of the house would include things like these decorative things. In case you're dealing with someone who's beginning to have cognitive impairment, you may also want to make sure that the lighting in the house is sufficient to avoid falls. You may want to avoid excessive mirrors in the house because that can cause confusion. All right, that's environment. Another thing to keep in mind for environment is if the house is in a building that doesn't have an elevator, and if the person is on a higher floor, are they going to be able to be mobile and get down safely? So these are considerations in the environment. And the last thing is the social networks available to that person. So in terms of friends, family, neighbors, voluntary groups, there are different organizations, community-based organizations. People talk about professional hired help these days. So these are things that would come under the social things around that person. So an acronym that I find helpful to remember all these aspects, I kind of remember this acronym of putting all the pieces together. Okay, so putting all the pieces together gives you a holistic approach. So pieces is PIECES. So that's physical, intellectual, emotional, capabilities, environment, and social networks. Okay, so we can repeat this again, but it gives you a slight framework to do an assessment of where your parents stand and where you stand as a caregiver. So when you have this,
what we could probably is that after this session, we can probably create a small checklist or a PDF which we can share with the participants or host on our website, so that they have it in a easy to do thing. I think some of the that I heard, some of the things are more like one-time sanity checks with maybe just a periodic review, while some things like social, etc., would be probably needing, and emotional would be needing ongoing, almost daily monitoring.
Yes. So some of them would be, maybe you need to check back on these things every 6 months or so. Like, for example, if you take someone's ability to drive, that ability might exist for even 2 or 3 years after you have this conversation. But it's something you need to keep in mind as part of your plan. Because see, the other thing is that when you're making a plan like this, everyone will come with a different context, with a different set of challenges. So when we talk about caring for the elderly, we're not talking about a very homogeneous group. So like, for example, when we sort of make an assumption, for example, that technology would be an issue with the elderly, I have learned in this pandemic that that's a myth. I have an 85-year-old who's in touch with me on WhatsApp, every week. He's updating me on his health. He's sending me things on WhatsApp. He's 85. He's very comfortable with a smartphone, with WhatsApp. I have other senior citizens who've learned how to use an iPad, who've learned how to get online and use Skype. So the elderly are not a homogeneous group where everyone has the same set of challenges. So, everyone will be in everyone's going to have a different combination of challenges. But what happens is something like the acronym of pieces just gives us an approach to how we will assess these issues for our loved one.
Right, and I think you made a very important point about context. Now, if I have an elderly who is not technology friendly, and I can afford a caretaker, then I can probably ensure that my caretaker is technology friendly. And so the principle remains. There might be a need for customization, but the principle remains valid.
Yeah, there's going to be a basic principle, and all of you being family caregivers and being compassionate people, you will be able to customize it because you will best know the needs of your loved one. So you may know. And remember, one more thing is that even if an elderly person is initially not comfortable with technology, if it's a user-friendly device, and if you can, just help them bust that myth that, they can learn to use a touch screen, they can learn to use technology, you may actually be able to get someone to be comfortable with technology. Unless there is some sort of cognitive impairment, which would be an obstacle to learning something new. But by and large, I feel that you can teach people to use technology. So those are the aspects: physical, intellectual, emotional capabilities, environment, and social networks.
Yeah.
Yeah. Now, I just want to point out how these things kind of play out with each other, just to explain. So for example, let's look at capabilities. Let's look at the capability of cooking and being able to nourish oneself. When would this be impaired? This could be impaired. It could be impaired by cognitive impairment, but before that, it could even be impaired if somebody has severe osteoarthritis and they are not able to move out of the house and go downstairs and do their own shopping. And if you look at the E in that checklist, they may live in an environment. They may live in a building where there's no elevator, and they may, not be able to come down 4 flights of stairs for their shopping. So a very simple intervention may be, and I've had families make this choice. The elderly person chooses to continue to live independently. They don't want assistance. They want to live independently. So what they do is they move from the 4th floor house to a ground floor house. So if the only issue was mobility and an issue in the environment which can be addressed, they basically move to a more suitable place, or they move to a building with a lift or whatever. So again, in your PIECES, there's sometimes little modifications that you can make to address. So you can make your modification in the environment to address something that's happening at the physical level, right? Then you can make a modification in the S. You can make a modification in social networks if you want to address something like emotion. Now, for example, there were, during the pandemic, there were elderly people who were literally stranded alone because children who were supposed to return from other countries got stuck in other countries. So there were elderly people staying alone, and this was an unplanned thing because their children were literally stranded in other countries. But these people, so if the E was a threat, their emotional well-being was a threat, the level of intervention was again at S, it was at the social networks. So it was neighbors, it was people in the community who stepped in to meet a need that was not being met by the children who would have usually been there. So again, your interventions will also be within this framework, and you can customize them. So that is sort of an example of how you can plan. And I think it's also important as a caregiver to have a plan in place for yourself. Because I know that many times children who are trying to care from a distance have to leave at short notice to be in another country to be with their loved ones. And at that time, they need to have things in place. So the plan should also include a bit of a checklist for the caregiver as well. So like, basic things like, excuse me, basic things like, making sure that your travel documents are all valid to travel with. Like that seems kind of obvious, but you'll be surprised at the number of people who suddenly realize that their passport may not have its validity to travel. So, things like your travel documents being in place. Then again, having a plan B in place for things at home. Many caregivers are part of what's called the sandwich generation. So they are caring for their parents, and they're also caring for their adolescent children. So they're in the middle. And so when they need to be somewhere at short notice, they need to have a plan in place for who's going to fill the role, who's going to fill the other roles that they are performing. So part of the plan will be, who would take over childcare, who will take over the other things you need to do in the place that you usually are in. So that would be part of your care plan as well. And one thing that I also want to mention is that for people who have elderly parents who are staying alone, I think a very important part of your care plan must be a trusted person in the community having some sort of access to the house, because there could be this terrifying situation where if you're trying to contact your parent and they are not picking up the phone or responding, you're going to need someone who can get into the house safely and make sure they're safe. And these days, because of the way our locking systems and safety doors and security features on our doors work, it's often very difficult to get into the house. Many windows these days have bar grills on them, or box grills on them. So it's really difficult. And you lose precious time in that. So part of your plan, and this would probably be your intervention at the level of social networks and environment. So your environment, your assessment of the home would be, what is the access through the door like? And the intervention would be in your social networks, who would have the key to the house, or who would have some form of access to the house? And therefore, would it be, yeah.
Like,
and I'm sure,
talking the other day, like the doctor had increased the dosage for one particular pill for my mother, which caused her to fall asleep mid-conversation and in the drawing room itself. And our next door neighbor didn't have the key, right? So it
did not.
Yeah, I mean, it might not even be an emergency. It could just be a situation, right?
Yeah.
Where the anxiety level sitting in Mumbai or wherever would then shoot through the roof. So you're absolutely,
yeah.
It's just, like you said, the key in preparedness, it's about one, looking at the emergency, B, what kind of a support system that we have, and what are the types of contingencies that we are sort of looking at, both for the patient as well as for the caregiver.
Yes.
Irrespective of how geographically distant those two locations might be.
True. Yeah. Because during the pandemic, I even had family situations where the parents were in Bombay, and the daughter, who would usually be in Bombay, was in Bangalore for work and then got stranded in Bangalore because of the lockdown. And so she became a long distance caregiver overnight, and she just had no option but to be long distance. So, in situations like that, she needed to have her networks in place in Bombay.
So I think that also makes a very important point. Like in engineering terms, we call something as a fail-safe technology, that it can't be dependent on an individual.
True.
So it's going to be phenomenally difficult for any primary caregiver to think that they are dispensable in a way, but they need to create a backup that in case of something else, the support structure, the social network at the point of care has to be something that can compensate for at least 60%, 70%, so that the rest of it can be done long distance via phone or whatever. Yeah.
Yeah. So that's, So there needs to be, as I said, a network of friends, of relatives, of professional caregivers, if that is available in the community.
Correct.
But yeah.
So when we started off, we're looking at defining palliative care and symptomatic treatment in case of a life-limiting condition or a pain-causing condition. But like we were discussing the other day, the principles are very relevant for even when everything is hunky-dory. Maybe, just like, okay, your parents are approaching 65, 70, and you have to start doing this, even if there isn't a condition, they are fighting fit, and I use fighting term very carefully in the sense that when you try and intervene with parents, they might fight with you, right? Because they don't want you running their lives. So the approach and these principles should start, especially in geriatric care, should just start as a default setting, right? Like you said, the checklists, we should start doing these things even if there is no diagnosed condition.
Yeah, so I think what we really need to remember here is the importance of autonomy. Okay. So when parents or when anyone resists somebody else um, in some way taking over their lives, that's basically because nobody likes the loss of autonomy. And if we go by the principles of medical ethics, you have your four principles of autonomy, doing good, doing no harm, and justice. Okay, so let's take the first principle of autonomy. You may face resistance. You may face resistance when you try to have these difficult conversations because there may be a fear that autonomy may be lost. Okay, so there's a way to approach this, and I can't really give you. I can't give. I guess a formula, but all I can say is that you know your parents the best. You know how best to approach them. Maybe it needs to just start with a discussion like, that I'm going to be away. It's going to take me at least 12 hours, 24 hours, whatever, to be able to get back to the city. So, are there a couple things we can do so that, we can, and the other thing I think might really help is instead of being in a caregiver and care receiver space, if you come into it as care partners.
Yeah.
Okay, you're all care partners. Your parents are your partners. You are your parents' partners. You're going to partner in the way a care plan is worked out. And may not even need to be called a care plan, because if your parents are absolutely fit and fine, they may not like to be told that they need to be cared for. So it can just be a plan. It can be a family plan. Let's have a family plan that this is the thing, and there are certain eventualities that could happen. If they were to happen, then we'd be better off if a couple things were in place. Like, I know one difficult conversation that some children need to have is at the initial diagnosis of a cognitive impairment of a parent or any neurological deficit. There's a difficult discussion where the accounts and finances, okay, which were always operated autonomously by an individual, will now need to introduce a joint holder or either or survivor, some sort of mechanism. That's a difficult conversation. I know some people breeze through it very easily. I know a lot of my patients have just introduced one of their children as a joint holder. And it really helped in the pandemic because they didn't need to go to the bank. Their children were going to the bank and getting things done. But that's because maybe over time, the children and parents had built that kind of level of trust. And so they were comfortable. And I'll be very honest, family dynamics are different for different families. Within the same family, the parents may really trust one of the children and let that child be a joint holder. They may express concerns about letting another child be the joint holder. So these are all things which, again, will have to be customized with the family, within the family. But yeah, so there might initially be resistance, but there's probably a good way to start talking about it as a family plan. So things about like who would operate the account, maybe conversations like in case of an emergency, who would be the decision maker? Like would it? There's some parents who would like their eldest child to take a decision, a medical decision. And if these conversations aren't had earlier, then I have faced situations where there's a parent who's hospitalized. The parent is no longer able to give consent to a procedure, whether they want the procedure, whether they want admission, ICU admission or not. And there are two children, and one child wants admission and one child does not. And there has been no conversation earlier as to who the decision maker would be in case the parent could not take a decision. So, some of these things probably need to be discussed, and these need to be discussed in so-called good times so that when a crisis hits, these things have sort of been ironed out.
Yeah. So I think, like Bhavna also just mentioned, that financial conversations are tricky, right? Because many of us don't have a healthy relationship with our own finances either, right? So it just becomes a very complex thing. But taking a step back, so communication becomes a crucial aspect. And I would hazard that having a healthcare practitioner, a GP, or the doctor on your side to help have those difficult conversations instead of me as a child telling my parents something if it is coming from the healthcare practitioner. I think that makes things incredibly easy. And having therefore a professional as part of the team is going to be super critical, right?
So thank you for mentioning that, because actually communication is also a very important aspect of palliative care. It's one of the whole thing of honest communication. But here I'd like to add that if you could have your GP present, that would be great. But um, it's not so much that it needs to be the GP. It needs to be someone who your parents trust and have faith in. So it could be the GP. It could be another senior relative that they trust and who could act as neutral. You could involve someone who would be the neutral advisor or guide to the process. So it could be an older relative that your parents trust. It could be the chartered accountant that they have trusted for the last so many years. The chartered accountant could step in and could help. Could help that process or that transition. So it doesn't necessarily have to be a doctor. It can be someone, because when we're talking about communication, we're also talking about things like trust and faith. And because financial conversations are very difficult, you would want someone who the parents really trust. So yes, of course, it could be their physician. It could also, as I said, it could be their CA. It could be a trusted friend.
So let me rephrase that. So again, context becomes important depending on the thing being talked about. So one very difficult conversation to have with an independent elderly person is to try and get them to get 24-hour help, for example. There it becomes a conversation, I don't have enough work for this person, and why do I need this person at all, right? And it'll cost X amount of money, and even if you have the money, they're not used to spending that much money because they grew up and lived in a time where inflation wasn't what it is today, right? So in that case, an elder relative might make so much more sense than maybe a doctor, right? In case of financial issues, the CA might make sense if there is one, or somebody else in the family who's seen to be a prudent person when it comes to financial matters. So I guess context specific, trusted, third party objective person who can help you have the conversation instead of you appearing as the bad person trying to impact that autonomy that you talked about, right?
Yes. So trusted on both sides. And that comes because that person is known to be a neutral and objective person. And therefore, also the preparedness as a child to maybe have that person tell you something that maybe you don't want to hear either. So for example, suppose as a child, you really feel that the parent needs 24-hour assistance, okay? And the parent is resisting the idea for whatever reasons that you suggested. It might help to take a step back and ask yourself, like when I say yourself, I don't necessarily mean you, Aneesh, but I'm saying the situation. The person can ask themselves that, why do I want 24-hour assistance in the house? Like, what are my fears? Where is this idea coming from? Is it something that I think my parent needs, or is it something that I think I need?
Yep.
Because oftentimes, one of the emotions that long distance caregivers deal with is the sense of guilt and a sense of not being able to be there. So sometimes some of these interventions which they want to have for the best intentions for their parents might also at some very deep level be their way of dealing with their guilt as well. So it's really important to be able to understand our own emotions and maybe understand why a fiercely independent parent would not want 24 hours assistance. And then maybe what you could do is then find a middle ground. So maybe, like I know I have a 93-year-old patient, fiercely independent woman. Her son also wanted her to have 24-hour. She wants someone staying at home, someone coming in the day, someone at night. She refused because she said that I just need someone to come in and help me with the cooking, and once in the evening with any little errands. And after that, I just want the house to myself. And she's managing like that. I mean, that's finally what was done. And we realized that her son's fear was that she may slip and fall at night, and that at least if there was someone in the house, she would be. I mean, there would be someone in the house in case she had a fall. But so far, she's refused to have someone in the house at night, and so far she's taken all other precautions. So there's handrails, hand guards near her bed, so when she gets up, she has the support. The room has been rendered safe so that there's nothing slippery in the room. All carpets removed so that there's no question of tripping on a carpet. All chairs with wheels, like how sometimes computer chairs tend to have wheels on them. Those are removed from the house because those tend to also slide. So any risk of falls has been removed. The bathroom has guardrails on either side of the toilet bowl. And she's agreed to keep the light on in the bathroom and the passage leading to the bathroom, keep that on all night so that there's no risk of falling. So she could reach some sort of middle ground, and then there was no need to have a night person stay. So sometimes it might also help when there's resistance to try to find a middle ground, something that makes both parties, as I said, they're care partners, not caregiver and care receiver. So maybe both can collaborate and work out a plan.
Right. I think there's a very crucial aspect that you brought out because many times it's the fear and uncertainties and hyperactive imagination of the caregiver, which might be creating a situation which is not really. Yes. So we talked about autonomy. We've moved to the other three aspects, but there's a question that has come up that one of our participants' father has been diagnosed with a cognitive limitation, and he's losing confidence in financial matters and gets anxious and on the verge of breaking down. Okay. The question is, how can we, and I'm saying this verbatim, how can we help him and ourselves by being strong for him? You can address this right now if you think it's better we talk about the other three aspects and then come back to this. Either way.
Yeah, so we can actually combine this as a kind of a case to understand the other three aspects. So you're talking about the four aspects of ethics, right?
Yeah.
We're talking about three aspects. Yeah, okay. So we're talking about autonomy, malfeasance or doing good, non-malfeasance or doing no harm, and last is justice. Okay, so when we want to do something, when we want to have an intervention, we want to sort of make sure that in our mind, this checklist is in place, that what we are doing is ethical. So it respects the person's autonomy, it will do good for that person. Even if it doesn't do good, it shouldn't do harm to that person. And lastly, it should be fair and just. Okay, so now in the case of someone who's got a cognitive impairment and needs help with finances. So now, is this parent resisting the idea of the children helping with finances, or?
So what it says, the question says is that my dad is losing confidence as he's forgetting a lot of important information related to financial matters and gets anxious about it a lot. So it reminds me of a situation where a person might be completely on the ball by saying, this is what my mutual fund looks like, this is what my bank account looks like, this is what my insurance papers, this date, that day, and have always been doing things by memory. And suddenly when they're not able to remember those dates, there's a anxiety, panic, confusion. And
okay, all right.
Maybe
so the first thing we do, so the first thing we do is we understand that the anxiety and panic is obviously coming out of the fear, okay? And it's fear because there's a fear of losing control, all right? Because at the early stages of any diagnosis, the person has what we call insight, which means they have an understanding that there's some condition, okay, and that there is some dysfunction happening. And that's a very frightening feeling for that person because there's a sense of loss of control, okay? loss of autonomy. So what we need to do is just understand, first of all, that that's where the anxiety, sometimes this fear can manifest as aggression, can it manifest as anger? There's different ways it manifests. But as family caregivers, if we understand that this is happening because of the fear of loss of control, the first thing we can do is try to give a sense of control being given back to that person. So for example, if this person was always aware of their mutual funds and accounts and everything by just memory alone, let the person now be encouraged to have all these things written down in a way that they can see them. Okay, so if it means getting a passbook updated once a month, or if the bank can send e-statements or whatever, but if the account can be physically seen from time to time, whatever these mutual funds are, whatever these assets are, if a list can be made so that the person, and the person at the early stages, you can also explain to people, they will understand. So you can explain that even if they knew everything by memory at one time, they might need to write things down now, just as when we were children and young people, we didn't need glasses, okay? But with age, our eyes required some sort of assistance or aid, and that is in the form of glasses. It doesn't mean anything. It just means that now you are using glasses so that you can help your eyes do their work. So similarly, even if you had everything by memory at one time, now if you write it down, it's just that you're helping a brain that's aging by helping it write things down instead of having to keep everything memorized. So maybe having your stuff written down will help.
Absolutely. And the other thing that I hear as a subtext from you is that, because the question said, how can we be strong? So I think the key thing for both the patient and the caregiver to work on is not fighting something which might not be treatable or curable, might be only it's a condition that needs to be managed. And like you said, do good, but cause no harm. So do good. Having everything in front of them in a file is a way of doing good. So that they can say, these are the 5 insurance things and 4 mutual fund things and 1 bank account. It's in one place. Anytime you want to know, you can take a look at it. I will ensure that every month it is updated. So loss of control and autonomy is addressed for the patient in that way. So it's actually doing good because at any point in time, they know they can refer to it and be reassured. Do no harm. I don't know, I'm just creating something on the fly here, could mean something like, maybe this person was an active investor, but doesn't trust his or her decisions anymore. So you let him or her say that, okay, buy this, sell that, but don't actually do something about it. It reminds me of this friend of mine, Vishal, whose grandfather was very active in the stock market, apparently, and he's 80 right now. So he keeps telling his grandson that, oh, you should have sold this and you should have bought that. Nobody does anything about it, but they engage in the conversation. Like, Nanaji, what should I buy now? Kind of a thing.
Exactly. So the question, how do we remain strong? I think that's the question, right? So remember, strength. So strength as the caregiver, okay, or as I said, care partner, but just for the sake of understanding the caregiver in this role, strength is an internal thing. Okay, it's your resilience and your ability to accept and adapt to a situation, right? Strength should not be manifested externally. So there should, for example, you should avoid arguments at all costs. Like if you need to reason with a person, if you need to reapproach a discussion, if you need to rephrase something and check back, suppose they ask you to do something like buy or sell something and you're not sure if it's the right time, try not to engage in an argument at that time, because the argument will again threaten the sense of autonomy and will further feed into that anxiety and that lack of trust. If it's not a time-sensitive decision that needs to be taken, see if you can give it some time and return to it, maybe return to it in a different way, and see if you can sort of, do what needs to be done, but taking that person on board with you, so that it doesn't seem like at some point people are taking over this person's life and this person has become a passive bystander, because that is where the loss of autonomy and the anxiety starts.
So could you share with your experience some examples of the balance between doing good and doing no harm?
So,
Just
so one,
yeah.
because this off the cuff, what I'm thinking of is, now I have some patients who are, a couple of them were, I'll take one example. She was an elderly woman, and she loved wearing her, she loved jewelry. Okay, she loved traditional jewelry. And at some point, it was necessary for the family to have a full-time hired caregiver come in. Okay, someone from a bureau. And as is the case with bureaus, there was a rapid turnover of staff happening. And at some point, there was this fear about the safety of the jewelry that she was wearing, because there were times when the family members were out of the house, or at least out of the room, and she was alone with the caregiver. And there was an incident where possibly one of her bangles went missing. And then there was this decision about what should be done. Now, to take off her jewelry and put it away for safekeeping would have been very traumatic for her. She resisted the idea. It was discussed with her, but she resisted the idea. She wanted her necklaces and her bangles and her rings. So at the same time, we had to balance her safety and, of course, the safety of the family, etc. So we thought of, and this is where in caring, you learn to sort of just find out creative ways to do things. We went to a I asked the family to go to a dress jewelry store and get extremely similar looking jewelry. And almost the same. And that when the lady was going for a bath, the family asked that she remove it for the bathing purposes, go for her bath. And then they very gently replaced the jewelry with the dress jewelry, and they put her real jewelry away in the locker for her own safety. Now, this brings up the question in ethics of what we call the ethics of deception. Okay, is it ethical to do something which would count as deception, like replacing jewelry? And this is where your balance of do no harm comes in. What was the intent behind this action? It was to do good, because it was to protect her jewelry and protect her from potentially exploitative staff. And because it didn't cause her any distress, she was still wearing her jewelry, it did no harm. And therefore, we had this, we didn't feel a burden of guilt that we had done something unethical, because we balanced, do good with do no harm. And so things like replacing, like, for example, many times when you're dealing with a person who has cognitive impairment, you have to sometimes allow a little bit of stepping back from the truth. Like you have to use deception sometimes for their own safety. And at that time, you are balancing do good with do no harm. So if you have to tell a white lie for the sake of that person's well-being, then you're balancing those two requirements.
So in this example, I think it comes out beautifully on how the balance can be maintained. Now, just getting a little creative here, that there would be times when the fears of the caregiver are so overpowering that though the intention might seem very clear and ethical and avoid trauma, it might actually end up being a situation where, if found out, it would lead to a loss of trust, right?
Okay.
So, there might be situations like that as well. So how does one really, because again, context, every time, I might, I might have a fear of my mother driving, and so I might insist that I need to have a driver, and I might lie to her and say that the doctor said you can't drive anymore because of your eyesight. Now that's, really the next time, at least my mother would definitely ask the doctor, did you say something like this? And the doctor's going to say no. And I'm going to be in deep trouble.
Yeah, so that's why the ethical way to do this would be, if you do have let's just take this example. So as a caregiver, you are worried about the safety of your mother driving, right? So maybe the best thing to do is take a medical opinion on it. And a medical doctor would they would check the eyesight, they would check the color vision, like to make sure that blue and green and red can be clearly distinguished. Okay, so they will check color vision, they will check visual acuity. And if you are concerned that the person if you have reason to believe as family members that the person may be becoming a little forgetful, there may be a little bit of cognitive slowing, and you share this concern with the doctor, then the doctor may ask a neurologist or neuropsychologist to just do a cognitive test. And if you have all your documents in place saying that it is safe for the person to drive, then at least as a caregiver, you are convinced that it's safe for the person to drive. And similarly, if the documents show that it's not safe to drive, then at least you don't need to indulge in deception because the documents say it. So I think what you can do is when it is possible to involve an expert opinion and tell the truth, then by all means use that expert opinion.
I think the other advantage of getting an expert opinion is that when I, as a caregiver, am going haywire in my fear, I might need the reality check. It's not just the patient or the care.
Yeah. Which is why palliative care, I think at the beginning I did say that the unit of care for us is not just the patient, it's the patient plus the family caregivers. Because most of the time, a lot of things are happening because the family caregivers have fears, a lot of issues, and that's not a bad thing. I mean, it's natural that they will have these fears and concerns because they love their parents, they're trying their best, and they're shouldering the responsibility. And so we need to balance that, and we need to acknowledge and honor that the challenges and the issues faced by the caregivers are also very important. So if a caregiver is worried about a parent who's staying alone and the safety of that parent driving, then that's a real concern and it needs to be addressed. But a concern like that can be addressed with the help of experts.
So let's just put this in the context of long distance caregiving now, right? So, like you have the pieces checklist of things. For long distance caring, do you think it makes sense that proactively one sits down and says, okay, come what may in the future, these are the 5 rules of engagement we will have, and we'll have a 6-monthly. I mean, it sounds very business-like, but I'm saying, sort of having a 6-monthly review of, like state of the nation, as the president would do it, right? So doing something like that, do you think have you heard of such things being done in families?
So I think, I have, but as long as what I would say is as long as it is collaborative. So even if you want to decide that these are the 5 things that we'll do, it's really got to be a collaborative process. Like it's got to be something that the parents are okay with as well, and that the children are also okay with. So for example, if the child says something like, I'm concerned about you living on the 4th floor and I'm worried about you climbing the stairs, and there's a heart ailment and I'm worried, and so that's why I think we need to really consider moving to assisted living, and the parents say, no, we want to live independently, then maybe the middle ground can be, as I said, moving to an apartment which is on a ground floor, so that at least the fear, or moving to a building with an elevator, so at least this fear of climbing staircases and stuff is addressed. At the same time, the parents retain their autonomy and decide that they would still like to live independently. And then any family decision can be reviewed. And again, the family can decide. They can decide to review it every 6 months. They can decide to review it every year. That's up to the family to decide internally. But as long as it's collaborative. And I think the best way to make sure it stays collaborative is to keep in mind that it's not caregiver and care receiver, it's care partners. You're partnering in a family plan.
No, absolutely. And I think, so in view of the care partnership, right? So a care partnership is going to be healthy if both the partners are feeling good about something, right? So one question that came in was that, you know, so this family I know, elderly couple, they're like one step removed from immediate family for me. So there, they discovered that by chance they hadn't done the regular lipid profile, sugar test, etc., for 3 years because they didn't anticipate anything, right? And suddenly, my aunt, she lost a lot of weight and it was diagnosed as diabetes, and now everything required is being done, right? So there are certain conditions that one can address through, like, for example, annual medical checks or 6 monthly tests or whatever the case might be, even when there is no specific diagnosis that might be there as a preventive measure. There are certain other anticipated limitations that might exist specifically related to neurology or cognitive impairments, which one doesn't think about checking. So one of the caregivers that we talk to often went through a lot of struggle to figure out how to get her mother to a doctor to get a confirmed diagnosis of dementia, and she was just worried, concerned, but not able to get a conversation started and get that diagnosis done. So now that we are making these checklists and tools with you, I'm wondering, is there a way for us to make a checklist of, if you're at 60, then once in 2 years, you need to get these 5 conditions checked periodically because you never know, kind of a thing, right? For maybe Alzheimer's, Parkinson's, dementia, maybe something else. Is there some protocol like that? Is there something that you recommend? Top 5 things that you need to do?
Okay. So for dementia and Alzheimer's right now, there's no screening tool. Okay. There's no screening tool. So you know how, for example, preventive medicine, if you want to prevent, in women, you want to prevent, for example, breast cancer. So mammographies every 5 years after a particular age are a screening tool. Or in men, prostate-specific antigen, PSA, is a screening tool for prostate hypertrophy and prostatic cancer. There is no such screening tool right now in Parkinson's or Alzheimer's. However, there is a lot of preventive stuff that we can engage in, like, for example, nutrition. If the person is diabetic, then very good sugar control. So we'll start with very good sugar control. So very good sugar control. Now, how is that done? With strict diet and exercise. Okay. Unfortunately, exercise has never been promoted in a huge way by the medical fraternity, but it's really, really important. So even half an hour of just walking, on a level surface, if it's the elderly and if they're not comfortable with inclines and with gymming and stuff, then just walking in nature. If you have a park nearby, or if your housing society has a garden or something. So you know what we say, green time as opposed to screen time, okay? So the same time that you would spend in front of a television or a screen could be spent in the outdoors for about half an hour or so. So exercise, then keeping mentally engaged. So following retirement, finding other activities. And this comes back to the pieces model where you use the C of capabilities. So whichever capabilities you have with you, you optimize those capabilities. So maybe you kind of, after retirement, you go into something like voluntary teaching or volunteering with a community organization, or maybe looking at a second career somewhere part-time, that kind of thing. So keeping the, cognitive function engaged. So nutrition, exercise, cognitive function, engagement, and good sleep hygiene. You know, these days, a lot of people have really disrupted sleep cycles. So they stay up very late watching TV, watching movies, you know, all sorts of things, and then they go to sleep late. And then, so the whole sleep cycle is disrupted. This is actually not good for your cognitive function. So things like prevention at this stage, because right now we do not have screening in place for Alzheimer's and dementia. So we can prevent things. And by doing these things, you build what neurologists call the cognitive reserve. Cognitive reserve is this concept that with the brain, even if the brain is undergoing physical age-related changes, if these interventions are in place, nutrition, exercise, cognitive stimulation, and good sleep, there's some reserve in the brain that the brain can fall back on in spite of physical changes. So we need to actually prevent neurological decline. Right now, we can't screen for it. And the other question as to when do you see a neurologist? I don't believe personally that there should be an age cutoff for this. So I don't think that, you know, at 60 or at 65, one needs to start getting these things done. I think it would be more of a, it's a more case-to-case thing where when the person starts showing signs of either memory loss, memory impairment, getting lost on familiar, like if they were generally taking a familiar route to get some shopping done and they find that they're finding it difficult, they're getting lost in familiar territory, that would be a warning sign. Memory loss is a warning sign. Now here I would like to say that when we say memory loss, we don't mean things like, for example, not remembering where you've put the keys, okay? Things like that are normal. But remember, I kind of say to people, it's like this. If a person doesn't remember where they've put the car keys, that's not serious memory loss. If the person doesn't remember that they have a car, that's a memory loss that you need to be concerned about. If they don't remember what the car key is meant for, that's a memory loss, okay? But something little like not knowing where you've kept the keys, not being able to recall the name of your second cousin's wife's brother who you met at a wedding 2 years ago. If you don't remember that person's name, it's okay. But you don't remember the names of your children or your grandchildren, then maybe there's something that needs to be checked. So when these symptoms start coming up, or unexplained loss of appetite, unexplained weight loss, okay? Unexplained withdrawal from usual activities. So here was someone who usually had a lot of zest for life and they're becoming withdrawn and there's a bit of a personality change happening. These are times when you do need to seek medical opinion on this. This can happen as early as 50. For some people, there is early onset Alzheimer's that can happen at 50, you know, I've seen people who are 50, 55, early onset. It can happen at 85, 90. So there's no cutoff like 60 or something where you need to get these tests done.
A lot of people seem to have got energized by some of these conversations, and I'm getting questions with Bhavna as one of the instigators. What about hobbies or things like creative expression? Can dementia be slowed down? Can it be reversed? Alzheimer's, for example. But before we move to that, I think which becomes condition specific, right? We're talking more principles rather than specific conditions, right? So one question came up that I'm about to get my checkup done. I'm 59. What additional tests should I get done just to be on the safe side? Any thoughts on that?
Okay, so is this a male or a female asking this?
It's a lady.
A lady, okay. So basically your checkup at this age, at 59, I think would just be a basic blood profile, a blood sugar profile. So, you know, you want to rule out diabetes mellitus because uncontrolled diabetes is a risk factor for dementia later on. Okay, so you want to rule out diabetes, get a lipid profile done. You can get a kidney. So basically diabetes, kidney function, liver function, If a 59-year-old woman has not had a mammography yet, then I think a mammography or at least a sonographic mammogram would be a good idea, especially if there's any history in the family of breast cancer, then you could get that done. Vitamin B12 and homocysteine, because again, B12 deficiency is one of the most preventable and common causes of neurological deficit. It's very common in India because of the vegetarian diet. And after a particular age, maybe even after the age of 55, 60, you could have a B12 supplement every day. It would do you no harm. Beyond that, I don't think you need to have additional tests, okay? It's very important, let me put it this way. We should live in awareness, but we should not live in fear, okay? So let's live in awareness of a healthy lifestyle. Let's prevent some of these neurological deficits. So as I said, I'll give you another acronym so that it's easy to remember, since it's neurological. So it's neuro, N-E-U-R-O, okay? So N is nutrition, so your diet has to be proper. E is exercise. U is learn to unwind, okay? Stress is a very bad stress is a predisposing factor. Uncontrolled stress is a predisposing factor for uncontrolled blood sugar, which is in turn a predisposing factor for long-term neurological damage and dementia. So U is unwind, or learn to manage stress. So N-E-U-R is restorative sleep. So your sleep has to be healthy. And O is optimize your brain function. So try to engage your brain in crosswords, word puzzles, number puzzles, games like chess. Language is a very protective thing. So if you can learn new languages, learn a new script, speak different languages. I tell people that if you learned Hindi and Marathi in school and you're out of practice now, read a Hindi newspaper once in a while, read an English paper on alternate days, and on other days, read a Hindi or Marathi paper. Get back into the habit of multiple languages. There are studies showing that the number of languages that a person knew were protective for that person to recover from stroke, from neurological deficit. So language is protective. And the question about whether dementia can be reversed. No, it cannot be reversed. So it is not a reversible process. However, its onset can be delayed. It can be prevented through these interventions that I just told you about. Okay, so remember the neuro interventions are preventive. They help build the cognitive reserve. And a larger cognitive reserve is protective, because when the brain undergoes natural changes because of age, so those physical changes are happening because of age, somewhere there's a cognitive reserve which the brain can fall back on, and it can still continue to function for some time. So you want to build cognitive reserve.
So there was this point about creative expression, hobbies, music. So I would imagine playing music, learning to play music would definitely fall within unwind as well as, keep the gears churning. Yeah. But and I've read some literature on how listening to music, especially the music from the times of the patient, has been found to be useful for patients with dementia also. So all of these things would address the need to unwind as well as the need to keep the cognitive actions working, right? So creative expression then becomes, okay, creative expression might be a term, but in a sense, these activities which help you de-stress and help you engage in a creative process are definitely going to be helpful in terms of delaying the process.
Yes, they are, yeah. Because the brain has this concept called neuroplasticity, okay? So it's literally the ability of the brain to lay pathways. Like, it was believed, the old school of thought was that the number of neurons that you're born with at birth are the number you will have for your whole life. That has changed now. And it is possible to learn and relay pathways. So creative expression, music, these are all extremely good. Like their artwork, as I said, writing different scripts. Creative expression using a couple of, like using, for example, the hands, the ears, and the eyes together also enhance coordination. So things like artwork, calligraphy, knitting, I mean, n number of activities, but where you're using your hand, you're also using visual. If you're learning music, you're using the ear. If you're singing, you're using, a number of complex pathways. So they are very helpful.
So essentially, in terms of the key senses, so any multi-sensory experience would effectively work. Now, coming back to the long distance part of it, if I'm sitting 5,000 miles away and I have a parent who's, or a set of parents who are living on their own, I might not be able to notice any of these not knowing what the car key is for kind of situations, right? Is it fair to say that the social network becomes very important? And then, if you have people who are calling in once in a while, or how do I get that information objectively? Because the patient himself or herself might not be able to register those symptoms, right?
Yeah, so they may not, but if it's parents staying together, then one parent may be able to report it about the other. Okay. If it's a parent staying alone, even if you're staying thousands of miles away, if you could at least maybe once a day be on a call with that person, I think you will intuitively pick up at some point if you feel that this person is beginning to have issues with memory. You can probably, try to keep the conversation going in such a way that you can sometimes check back about, some event that happened last month or something like that. So that would be what you could do as an individual. And as I said, in the pieces checklist, where you have S for social systems and social networks, you would, if your parent is alone in the city, you would want your parent to be networked with other social networks. So either groups of friends, you can be in touch with the friends, with relatives, if they would like to volunteer with a community-based organization. They may be part of, for example, a scripture study group or a music class or some sort of group activity. So you need to probably identify who these social networks are, who are your contact people who could report back to you, and who need to also have that comfort level with you. Because some people may have concerns about someone who's living alone, but may not feel comfortable to contact their children and tell them, because they may feel that that's very intrusive. So there needs to be a level of comfort with a few people that they feel comfortable enough to, pick up the phone or email you and let you know that, there's something here that's concerning us and we need you to look into it. So I think that would be a good thing, to build a network of people who will get back to you because they trust you.
Sure. So I think that's definitely going to be crucial. But how about this? Again, now we've talked about how there is heightened anxiety, guilt, probably to a certain extent, and a set of these negative emotions. I mean, they're called negative, as I'm constantly reminded. There's nothing negative about an emotion, but so this is what a long distance caregiver is dealing with, right?
Yeah.
How would preparedness and other such tools help them deal with these emotions, which are enervating them, exhausting them in a better way?
Yeah, so I think what happens is these emotions are natural because, as I said, they're not negative. They're natural emotions because they care and they care for and they love the parent. So how preparedness would help is it would help channelize those emotions into something more concrete so that there is a sense of having a plan in place, right? Because see, if suppose someone is just worrying but not able to do something concrete about it, then it's really like, leaving the headlights of the car on at night, right? So it drains the battery, but the car doesn't go anywhere. So what you need to do is, if there is worry, concern, etc., then it needs to be channelized into activities like reaching out to groups, reaching out to social networks. First of all, reaching out to the parents and figuring out a care plan, reaching out to relatives, trusted people, and trying to have a plan in place. It may not make the person feel 100% good, but at least it'll give the person some sense of maybe just a sense of control, a sense of having a plan in place. So it's not completely, there isn't complete uncertainty and unknown. There's at least a sense of knowing who the doctors are, knowing who the people around the loved ones are. I think that would help. And there will always be a degree of uncertainty and fear and guilt. That's something that I guess and I know there's lots of caregivers participating today, so I'd love to hear them too. I've been doing all the talking, so I'd like to hear if anyone else, for example, has anything they'd like to share about how they've coped. Because another thing that's really important is self-care, but that would probably be an entirely different topic. But yeah, self-care and so how they cope with these negative things. So
I think self-care is something which is very, very crucial. And we'll get into that and we'll just open up where everybody can participate. And I'll stop the recording for that section, or maybe we'll just cut it out later so that we can maintain privacy and stuff like that. But I wonder if there are any other questions that anybody would like to share or just, raise their hand.
Yeah, I just want to see. So with confidentiality, would it help for if someone would not like to be recorded, would it help to turn off the camera then? Or I guess the name will appear, right? Confidentiality is an issue?
No, we'll just cut out, we can just cut out we're streaming live. So yeah, that might. So what I would suggest is if in case anybody has a question, they can send it to me directly.
You can send a question in, yeah. And I just wanted, I know that I have asked some of my caregiver friends to also participate so they could share some of their learnings. I'm just checking if Urmila's here. Urmila, are you there?
Yeah, she's there.
So I just wanted, I know Urmila's had a remarkable journey, and I can let Urmila share that, but especially her learnings from it and how she, especially in the lockdown, with no staff, no support, how she managed.
We'd love to hear from Urmila. Urmila, why don't you?
In the 28th
Urmila, your mic is.
Sorry.
Yeah, we can hear you now, Urmila.
Yeah. So no, I'd love to share, except that my mother passed away in the 28th, so the 28th of October. So I'm through with my journey. So if anyone else wants to share, then they may have a real problem right now. So I'd rather give them the time, and if there is time, I'll definitely share. I don't mind at all. But maybe somebody has an urgent question. So maybe better to give them a chance now.
In case anybody has a question, kindly raise your hand while we listen to Urmila tell us what she thinks would help others. Would that work?
Can I just say something?
Yeah, please.
Urmila. So I just want to share that we're not through with the journey, because for us, the family care partner was as important. So you are going through a process of healing as well. And I think when you're ready to speak about it, it doesn't have to be today, but whenever you're ready to speak about it, I think your learnings in terms of self-care would probably really help others who are going to be on that journey too. But as I said, when you're ready, so it doesn't have to be today.
No, I'm ready, but briefly, I just wanted to say that it is still, it's very, very difficult, because you've actually put all your needs, not because you're self-sacrificing, just because that's the situation. You have to put the needs of the patient, your parent, first. So, once the parent goes, there's a huge vacuum, especially if you're single, if you're a single caregiver, sole caregiver. But for me right now, the thing is, how can we, and this would apply to even those who are right now active caregivers, this is what the message I want all of us to take. I keep sharing this with friends who are my age, who are taking care of their parents, to please not neglect their health, because if Alzheimer's, dementia, whatever it is going to hit us for whatever reasons, let us have this. I love this term, cognitive reserve. Let us build on this NEURO, so that, because we may not have the kind of caregivers that our parents had, that we gave our parents. Times are changing, and we don't want to suffer alone. Then I think this is important. So more than share anything else about the journey, I would strongly make a huge, strong case for all of us to start taking care of ourselves now, not wait till the sugar rises to that level, not wait till, the CAT scan shows up something, that we all in India, I feel we tend to neglect, especially in our cities. We take things very lightly until it reaches a crisis point. And that is the one thing I want to share. And other things I'm happy to share if there's time, but
Thank you.
just
Thank
one
you.
more thing is avoid. I don't like giving. I don't like giving sort of. There's no diktat or anything like that. But I notice some of my friends and relations are still very. Oh, take her to hospital. You know, I'm not against doctors and hospitals. I think there are friends, but if a person is very old, this is a very difficult decision to make. And if one can keep the person at home, if one has the resources, it's always better end of life in the home with the children, with people around, rather than in a hospital with tubes. I am not making any general statement here. I know a lot of us don't have resources, space, everything. It may be necessary to go to hospital, but this is a very difficult decision that I took. I don't regret it, but it's something that we need to think about. That's all. These are the 2 points I wanted to make. Yeah.
Lovely. I mean, thank you so much. I'm sure if you could take up the time to join some of our support groups that happen, a lot of active caregivers would benefit a lot in terms of specific situations and learning, because you have a lot of experience to pass on, and though it might not seem so, a lot of people would be really appreciative of that pain that you've gone through, and therefore they can learn. That would be really great. Are there any questions that anyone has? So there don't seem to be any questions, but Dr. Leena, I'm going to need checklists, pieces, euro, right? And what conditions should someone preventively try and look at? And maybe we can put them on our website so that people can download them and use that. But I think the key theme in everything that we're talking about right now is coming back to what you started off with. How can we be better prepared, right? So any closing comments, Dr. Leena?
I mean, all I can say is I understand that as caregivers, everyone's at a different stage in this journey. I want to acknowledge that everyone is definitely trying their best. And I'm sure that if it was a group discussion and everyone was, if we were all contributing, there'd probably be so many things to hear from others, so many learnings from others. So my closing comments are that we should probably acknowledge that everyone is trying their best. And we should probably continue sharing if it's through the Facebook page or if it's through support groups. And honestly, the experts in the field are family caregivers who've been through the journey. And doctors like me have been just we've been a part of the journey because we've been hand holding with those caregivers. But I think the people who've really been through it and who really lived through it, they're the experts. And I think, it'll be a nice thing if they can also share their experiences through the support groups, through your Facebook page. And the closing comments are, of course, that I just wish everyone a lot of strength and resilience. And I also hope, as Urmila said, that everyone takes good care of, you have to all take good care of yourselves as well. Self-care is very important. And, please put these principles of nutrition, exercise, de-stressing, restful sleep, and optimizing brain function. Please put them into practice as soon as you can and take good care of yourselves. And of course, while doing that, take good care of your loved ones as well.
Wonderful. Thank you, Dr. Leena. Thank you so much for your time today. Just a quick reminder that while this session has been recorded, it would be edited a bit. And this is the 18th webinar on a variety of topics relevant to caregivers. They can be accessed in the new year only for subscribers to the websites. I would encourage people to subscribe. I would encourage you to share stories of encouragement and empowerment with other caregivers. You can choose to do it on video, or if you would like to maintain anonymity, you can just let us know what you'd like to share, and we would be happy to tell your story on your behalf in a podcast and maintain that privacy. But what we have seen is that it is only stories that work. And we'd love to be able to help get your stories across to each other. So with that, thank you very much, Dr. Leena, and hopefully we'll catch you again very shortly.
And thank you all, Bhavna, Aneesh, thank you, Anjali, Nabia, and of course, everyone who participated. Thank you so much.
Right. And we will stop the recording now.